high yield impacts for clinical year clinical rotations. So without further ado, let's talk about the cavernous sinus, one of the spots of the brain drain. But before we talk about how blood leaves the brain, let's talk about how blood gets into the brain. Hopefully this image on screen, the circle of Willis, isn't too traumatizing for folks yet. Definitely an important topic, make sure that review and learn it. But I bring it up here to talk about how blood enters the brain and the rate at which blood enters the brain. So this is a high volume system taking in upwards of 600 milliliters a minute through the carotids, and then 100 to 200 milliliters a minute via the vertebral basilar system. That's kind of that posterior part that feeds the two vertebral arteries into the basilar artery. And so kind of conversely, one might first think, oh, it's all draining out through the cerebral spinal fluid production. That's not quite how it works. Kind of when I was first thinking, I wasn't quite as familiar with the venous system. But in terms of CSF production, it's only 20 milliliters of CSF produced every hour. And so doing the math really quick, that leaves just about 54,000 milliliters of fluid every hour not accounted for, not being drained out through the CSF system. And so that raises the question then, how is all this blood getting away from the brain, right? Because it has to go up and then it has to recirculate to be replenished to become oxygen rich once more. So that means that the bulk of blood is draining out through a venous system, kind of a standard venous system. One of the big differences, though, is basically everything at the neck or above doesn't have valves. So unlike in your legs, where a lot of those veins have valves, most, if not everything in and around the head has no valves, really just relying on gravity to assist the return instead of these one-way valves that build up pressure and then allow for fluid to flow up the leg. So that means kind of it's relying on this capturing system. So we have these large venous sinuses, and I just want to juxtapose that with the air-filled sinuses in and around the nose, under the eyes, and in the actual bones of the skull. These venous sinuses are really just big veins that are collections for a bunch of capillaries or smaller veins to flow into, and then naturally will be an easy return of blood back to the superior vena cava. And so this system is really optimized to have these large collection buckets and then allowing gravity to do the rest of the work there. So with that, this is kind of a architectural diagram showing the flow of blood through these different sinuses. And so we can think of these as big collection buckets, and then these collection buckets will trickle into one another until ultimately you reach the end there in the bottom right corner, the superior vena cava. But today we want to focus our lecture, as we were talking about, on the cavernous sinus and what lies in it, what lies around it, and what happens when it gets backed up. So we can first think of the cavernous sinus as potentially what is entering, what is feeding into it, and then where is it flowing. So first of all, it's going to flow, as we saw in that diagram and as we see here, into two other sinuses, the superior and inferior petrosal sinuses. Those feed into the sigmoid sinuses or other kind of collection buckets. And those are kind of what you see at bottom right of that image, those SPS and IPS. But it is fed by, it is receiving venous blood return from a series of different veins. Some of these were talked about in Dr. Z's lectures, some of them are not. I'm just kind of emphasizing them here, so this slide really makes sense. This image on screen is also only showing the left cavernous sinus and what is feeding into it. You can assume that the right cavernous sinus will have the same parallel system, but the kind of image left side from the facial vein, that would be the anterior part of the face, and then the cavernous sinus running posterior as you move right on that image. And so you're receiving blood from the superior ophthalmic, the inferior ophthalmic, superficial middle cerebral, and uncal veins. And so briefly, as the name implies, the ophthalmic veins are receiving blood return from the eye. The retina is a very blood-intensive organ, and so requires constant oxygen-rich blood, and so that's going to pool back to the cavernous sinus. Superficial middle cerebral vein receiving blood from the anterior parts of the brain, and then the uncal vein. And as you also see on this image here, the facial and angular veins are feeding into that superior ophthalmic. So this was an image from Dr. Z's lectures yesterday, but this is really showing how a lot of the blood from the anterior portions of the face are actually draining back into this region, kind of tucked underneath the brain. And we'll emphasize it a little bit more, but the cavernous sinus here is really sitting underneath that frontal lobe, medial to the temporal lobes, close to your pituitary gland. But as we see here, the deep facial vein, that really large prominent vein running underneath your cheek, that is feeding back into the sinus. And this will come up relevant when we think of if this sinus gets blocked, where will we see blockage? We'll see issues kind of everywhere that feeds into this vein. And so when we think of that, we can say, oh, we'll probably have issues around the eye, around the face, or other things that are draining into this cavernous sinus. So this right here is the real bread and butter of this lecture. If you don't remember anything else from this lecture, I'll emphasize these structures that either sit directly within, or as Dr. Schmidt was reminding me, just adjacent to, just outside of the cavernous sinus. There is either anatomical variation or even debates within the larger anatomical communities for what sits properly within each side of the cavernous sinus. Between the two halves of the cavernous sinus, there might be some communications, but you can really think of each of the sinuses as a cistern that's really sitting there on its own with 6 unique structures either within or just outside of. And we'll have a mnemonic for helping us remember this, but we have cranial nerves 3, 4, 5, 1, 5, 2, and 6, as well as the internal carotid. And the area of contention is cranial nerve 5, 2, and potentially cranial nerve 5-1 even might be actually kind of lateral to or actually just outside of it, running in the walls of the cavernous sinus. Still, that means, though, if you have some issue with the cavernous sinus, that will put pressure, that will impinge upon cranial nerves 5-2 and definitely 5-1. Other things to note is that you have your sphenoidal sinuses kind of located medial to the cavernous sinus, very close to, so if you had some sort of infection, something sitting in there, it could very quickly creep through the bones and reach into the cavernous sinus, as well as your pituitary gland really straddling the line sitting between. And so that means that sella turcica is really sitting in between the two halves of the cavernous sinus. So it's flanking both sides of that Turkish saddle, that sella turcica. So this is, again, just repeating this for redundancy, but you have your 6 structures, really thinking cranial nerve 5-1 and 5-2 being separate. And then your internal carotid being the 6th item in there. So how do you remember this? What's the little mnemonic that I came up with? I just remember the numbers 1 to 6. And so many things in terms of mnemonics are things that I try to make for myself, are things when you're on an exam and for the life of you, you cannot remember, which options to select on the multiple true-false section. Well, you can just start counting 1 to 6 with yourself. So with 1, we're actually going to think cranial nerve 5-1. So the ophthalmic division of the trigeminal nerve. And then we go to 2, and of course it will be cranial nerve 5-2, the maxillary division of the trigeminal nerve. For 3, now we're actually at cranial nerve 3, ocular motor. For 4, we're going to go to cranial nerve 4, trochlear nerve. So far, so good. At 5, this is where things get a little bit tricky, because we've already talked about cranial nerve 5-1, 5-2, which are the 2 parts of cranial nerve 5 that we've talked about. This is where we're using the Roman numerals kind of trickily. So we're going to think, okay, we're going to think V for vessel, right? Roman numeral V is 5, and V for vessel. So that's how we get your internal carotid artery, ICA, and that's how you remember that's kind of item 5 on that list. And then finally, item 6, cranial nerve 6. Again, you have 5 nerve or nerve divisions, and then 1 artery. And so if you just count 1 to 6, you can remember which divisions of cranial nerve 5 are there, as well as remembering V for vessel, V for 5, cranial internal carotid. Let's talk a little bit more about that internal carotid. Some of us have appreciated when we've removed the brain from our donors, but it follows this very tortuous path, this kind of snake and winding path through the brain. And so the image on screen left is showing kind of a posterior oblique view, where effectively the internal carotid is rising up through the neck and then diving through the cavernous sinus before diving back. And so there's this effectively kind of shows that it has this 3D structure where it is sitting in the cavernous sinus for part of it, and then it's sitting just above the cavernous sinus for other parts. The image on screen right really gives you appreciation just for how windy that cavernous sinus is as it passes through that carotid canal and moving through the internal carotid, as it passes through the carotid canal and then up through the internal cavernous sinus before snaking back and then splitting into the different components of your cerebral arteries. Important here because when we think about the sympathetic innervation, well, how do we get that in and around the face and around the eyes? If you'll remember, the sympathetic component, as compared to the parasympathetic component, of our nervous system is really emerging from C1 to T1 in the central spine there. And so we have our cervical chain ganglion right at the top, right near C1, and now those sympathetic fibers have to run the whole length of the body of the axons into and around the face to have sympathetic tone in the face. And so what it does is it actually sits along the internal carotid artery, forming a plexus of nerves sitting on the body of the artery there, providing nervous input to the actual face, to the eyes, and this is how you get effectively the sympathetic tone to your eyes, forehead, and other parts of the face. Because again, when a nerve leaves the central nervous system, it doesn't dive back into the central nervous system. And so it has to follow this path, staying somewhat outside of the central nervous system. I'll also emphasize here that since this is a sympathetic fiber, it's not going to have another cell body close to the eye. All the cell bodies of this sympathetic component are located in the cervical ganglion themselves. And so even though it passes through the ciliary ganglion, which is a parasympathetic ganglion coming from the ocular motor nerve, coming from parasympathetic tone coming from cranial nerve 3, this is actually going to go through that ganglion but not have any cell bodies in there. So just the axons will pass through and continue on to the lacrimal, to the eye itself, or the parts of the forehead innervated sympathetically. This will come up a little bit later, but just remember, you're only getting sympathetic, not parasympathetic tone right along the carotid artery. So this is just adding a little bit more detail here of the structures just outside the cavernous sinus. Again, the ones that we really want to emphasize would be the optic chiasm sitting just above it. We have our internal carotid kind of snaking back around. So the internal carotid both runs through and then comes back around. And that's how you can actually identify this is a posterior to anterior view. The fact that the carotid artery as shown is coming back towards us as the audience suggests that it's passed through and now coming back. Finally, that pituitary gland, though not technically sitting inside the cavernous sinus, if you have any problems within that, or conversely, any problems with the pituitary gland, you can see kind of translational problems back and forth. And then again, that sphenoidal sinus, a pocket potentially for infection and then damage to the cavernous sinus. So this is kind of just the completeness, but really just giving you an appreciation for all the surrounding structures. And so any damage to one of these structures can negatively impinge upon everything around it. So now with all this in mind, what happens when our cavernous sinus is blocked? Either internally or just after, we get something that's quite appropriately named the cavernous sinus syndrome, CSS. So uniquely, because you have this communication, but each side is relatively isolated, a big collection bucket, you could have unilateral symptoms on this list here. Now, these are some words that maybe we haven't seen, maybe we'll see them in FBC2, so I'll just break down what each of these words may mean. The first of which, ophthalmoplegia, is effectively a palsy, a weakness, or paralysis of eye muscles, of your extraocular muscles. Specifically, it would have to be one of the nerves innervated or running through the cavernous sinus. So if you're having a blockage on one of the sides, you'll see ipsilateral issues with moving the eye around. So running through the list, cranial nerve 3, our ocular motor will control our superior, our inferior, and medial rectus muscles, and our inferior oblique. Putting all this together, we're going to see issues with elevation, depression, and adduction of the ipsilateral eye. Most prominently, we'll think about this when we're trying to deviate our eyes medially. We'll see issues especially there. For cranial nerve 4, we think of palsy here. We're going to see issues with the trochlear nerve. And of course, that means we're going to have issues with abduction and depression of the ipsilateral eye. Again, once we're thinking moving medially, we'll see issues there because that's really when our trochlear nerve is most engaged. And then for audience participation, cranial nerve 6, where might we see issues with that if we have damage to cranial nerve 6? First of all, what's the name of cranial nerve 6, as we're still getting those nerves? Abducens, great. And so in the name, we should see issues with what? Great, abducting the eye, especially when moving laterally. Somewhat uniquely here, of course, if cranial nerve 6 is impinged, that one is basically going to have unopposed innervation from cranial nerve 3. And so no matter where the eye will be looking, you'll see effectively a shift away from the abduction, the side of abduction. So we can run through effectively what that looks like with some examples. So this is just kind of a normal cranial nerve exam. Maybe we've practiced this in our CSF skills or components, but you're just asking our patient to move their eyes around. So if we're thinking, okay, we're having right third nerve palsy, how might that look? And so here what we'll see is when looking right and looking straight and looking left, we'll actually see a depression of the eyelid, first of all, on our right eye. Now, we'll come to this in a second. This is called ptosis, and this is coming from issues with that sympathetic innervation. But additionally, what we'll be seeing here is effectively the eye is always being abducted away from midline. Again, these structures that are responsible from cranial nerve 3 are all effectively resisting or controlling the eye with the exclusion of moving it laterally. We'll kind of ignore the trochlear and the superior oblique for this, but effectively you're getting unopposed abduction of the eye away from midline. And so no matter where you ask the patient to look, their eye will always be deviated midline. With right fourth nerve palsy, this is what we'll see again. Really, we're seeing issues now with depression of the eye, as well as, once again, the eye being deviated pretty strongly laterally. Once again, we're seeing the abductors really being engaged. But actually, this is one somewhat uniquely, when you ask the patient to move medially, you're seeing the eye elevate. And so the trochlear nerve really comes into play when we're asking our patients to medially look inward. Otherwise, your eye will elevate without that kind of innervation from that superior oblique muscle. And finally, we'll ask, once again, for audience participation, what do you think will happen if our sixth nerve on our right side is cut off? If we're not really getting any signal from our abducens nerve? How will our eye be deviated? Will it be deviated medially or will it be deviated laterally? Perfect, yeah. So just kind of the exact opposite case of our third nerve palsy. When we're looking to the right, we actually see it kind of shift mid or looking forward. Really, our medial rectus isn't that strongly engaged, but as soon as the medial rectus starts to become engaged, we're seeing that right eye start to drift medially. And so no matter where you are, the right eye is not quite where it should be. And so you'll be asking your patient, again, to track your finger, and again, it'll be deviated medially no matter where you're asking the patient to track. The second list of symptoms, I guess, does that all make sense? I know that's a lot there, and we're trying to put together all these extraocular motor nerves. Feel free to quiz yourself with this slide. It's, I think, helpful for just appreciating the cranial nerves writ large, let alone for the cavernous sinus. Now we're talking facial sensory loss. Who here remembers, maybe using the mnemonic, which of the three branches are being impinged if you have some issue with our cavernous sinus? 1 and 2, excellent. So our ophthalmic and our maxillary nerves, our branches are being impinged, and so you're gonna see loss of sensation in these regions. You should still see that mandibular section still having sensation. So this is a really big clue that the impingement is actually in the cavernous sinus as compared to kind of higher up along the trigeminal nerve. You can have trigeminal neuralgia, and that can have kind of distributions in different components of the face, and the different components together will really pinpoint where the lesion is. This is kind of a tip for Dr. White. He loves localizing the lesions, and so this is a big part of neurology, a big part of neuroscience, neurosurgery, is using kind of our list of tools and our hints to put together where exactly in the chain of signaling is our neurons breaking down. And so, you know, neurology is very cool in the sense that you can get very precise with a couple constellation of symptoms and really know where our lesion is occurring. So this is the one that I hinted at before. In the context of Horner syndrome, you have this triad of symptoms. Horner syndrome is effectively a loss of sympathetic innervation. And so let's say we're having compression, again, we're having some sort of buildup of pressure or issue in our cavernous sinus. That's going to impinge on that plexus of nerves sitting around the carotid artery. And what that looks like is you could lose totally or partially your sympathetic innervation. And so you'll see ptosis, which is the drooping of the eyelid unilaterally, miosis, which is going to be effectively a constricted pupil, loss, because again, sympathetic innervation dilates and opens the pupil. If we think fight or flight, when you're in a scared environment, your eye is trying to get as much information in as possible, so the pupil is going to maximally dilate. And then finally, anhidrosis, lack of sweating in and around, especially the ophthalmic and or maxillary divisions. Once again, thinking kind of where our neurons are being driven. Compression of the postganglionic sympathetic plexus traveling along ICA, and then it's also very close to cranial nerve 6. And so what you can actually see is, depending on where our compression, where our infection, or whatever is causing issue in the cavernous sinus, you can also see kind of one or two of the structures running through the cavernous sinus being taken out. And so the internal carotid and cranial nerve 6 track very close together within the larger cavernous sinus. And so sometimes you actually don't see impingement upon the other structures, but you'll see issues with the abducens nerve and then issues in and around the carotid artery, including this Horner syndrome. And that would suggest you might have an infection more medially within one side of the cavernous sinus. Finally, those terms of proptosis and chemosis. Proptosis will be the entire eye bulging. If you have a buildup of fluid, the ophthalmic veins aren't able to drain. Now you're getting bulging in and around the entirety of the eye, while chemosis will be kind of a unique swelling of the bulbar conjunctiva. This is just a different constellation of what veins are getting backed up. And so now we're seeing a backup of everything except kind of the space in and around the iris itself. You could even have buildup of pressure in that vitreous humor space, kind of causing the iris to stay back. There are kind of different ways that this can look, but just know if you're seeing bulging in and around the eyes, this is a potential sign that this person has an infection or other issue leading to a cavernous sinus symptom. So here's the list of potential causes kind of put here for completeness. I'm going to dive into, I think, 3 of the most relevant ones for wards for clinical applications to take us home. The first of which is a pituitary adenoma. This is kind of our most common type of pituitary tumor and overall a very common clinical presentation, things that the boards love to quiz us on because there's a million different ways these things can look. Pituitary adenomas are considered benign, but they still cause problems in our patients. And there's 2 subdivisions. Now, when we think the pituitary gland, we think the production of hormones. And so if the pituitary adenoma is growing and producing a unique set of hormones, we can think of this as a functioning pituitary adenoma. That means that it's going to be causing changes in hormone secretions, producing too much, too little, but often too much of the hormones that the pituitary gland is responsible for. Conversely, a non-functioning pituitary adenoma will just be a growing and growing mass that might effectively lead to unilateral, sometimes bilateral CSS. And so that's kind of our hints. Oftentimes, if you have a functioning pituitary adenoma, you'll notice those changes first before you notice anything in terms of mass effect, the space occupying pituitary gland. And composed to the non-functioning, you're not going to notice it until it's taking up so much space that it's going to cause a problem. One of the most common, in fact, the most common type of functional pituitary adenoma is a prolactinoma. Prolactin is a particular hormone that is responsible for a couple of things, including the mammary letdown or the milk letdown reflex. And so this is one where you'll definitely see these issues before you see your larger cavernous sinus symptoms. In men, the overproduction, overexpression of prolactinoma will produce erectile dysfunction, low libido. In women, you'll see changes in menstruation or potentially infertility. And then in both men and women, what it will lead to is galactorrhea or an inappropriate production of breast milk. For example, this is, again, what tells moms to provide breast milk for their babies. However, in terms of prolactinoma, they'll be producing it when they don't have a child, or in men, any production of breast milk is clearly something clinically pathological. And Dr. White, I think, probably during January, will probably tell a story about him working with a colleague who actually had a prolactinoma, and this was actually the first sign that his male colleague had a prolactinoma, the fact that he had galactorrhea. So definitely something that you can see in the everyday world. The next potential cause of impingement cavernous sinus symptoms is a cavernous sinus thrombosis. It's a rare but an emergent issue. And I'm just kind of quoting here, referencing earlier how I talked about there are no valves in this space. So once we get any stagnation of blood or poor drainage, you're really likely to get a buildup of a thrombus or a blood clot in and around this space. Most commonly, this will be caused by infection. And so because of that infectious nature, we can think, do we have fever, tachycardia, hypotension, rigors, nuchal rigidity, and altered mental status? A lot of these terms, we might be thinking sepsis. Now, we are getting an infection really close to the brain, so it can really present like sepsis. However, if we're seeing the larger symptoms of cavernous sinus symptoms, again, any buildup in and around the eye, and or issues with moving the cranial nerves or moving the extraocular muscles, we can actually think that this isn't meningitis quite yet. It's actually an infection leading to a thrombosis in the cavernous sinus. And so all of these together should really kind of point to that picture. Now, how do we get infections in the space to begin with? Well, as I was talking about before, in the sphenoidal sinuses, those are sitting so close, and if any bacteria gets into that space, sets up an abscess, it's not too hard to imagine it spreading through the bone and then reaching right into that cavernous sinus. And so this diagram is showing that in this patient's left cavernous sinus, you're having a thrombus, and then that's leading to the proptosis, the papilledema, or the inflammation around the eye, as well as the congested left retinal vein. And so that's leading ultimately to our cavernous sinus symptom. Other potential etiologies for folks with acne, this is actually a really common cause, where picking at acne in and around the face is kind of considered a critical zone, this upper nasolabial fold being a risk for, if you pick at that area, this is a way of introducing an infection into the bloodstream there, and then once again, the infection can set up shop in the cavernous sinus. Finally, any infectious etiologies in the eye, if you're having drainage from the ophthalmic branches into the cavernous sinus, if you have an infection in and around the eye, that can quickly lead to thrombus in the cavernous sinus. Finally, and this is relevant in the world of vascular surgery and interventional radiology, an internal carotid artery dissection. You can have it from trauma surgery, or if you're introducing a wire into that, if you're trying to repair, let's say, an aneurysm in the brain, you have to go through the internal carotid. Well, if you're not careful there and you nick the walls of the arteries there, you can introduce a dissection, which is effectively when you cause tearing in the walls of a major artery. Other potential causes are, once again, infection or some autoimmune process, including sarcoidosis or atherosclerosis. This can just happen over old age and too high a blood pressure. You can just naturally get internal carotid artery dissection. Very scary, you're gonna lose blood to the brain, and what really looks like is you get this triad of symptoms. You're gonna get pain in the head and neck region, in part from the carotid artery itself tearing, but also because of ischemia leading to cell death. And this is gonna cause problems as well as increased pressure in that region. You'll likely get that partial Horner syndrome, once again, because the sympathetic plexus is tracking along that carotid artery, so any damage to the carotid artery will negatively impact that sympathetic tone, as well as any ischemia from lack of oxygen reaching that will, once again, really cause immediate impact on the nerves. And then finally, you'll see cerebral or retinal ischemia. That means basically you're not getting blood flow to the brain. Your internal carotid is the major source to the ACA, MCA, and PCA. Of course, you have the circle of Willis as a backup, but the carotid artery, as I showed on that first slide, is responsible for about 70% of the blood that's reaching each side of the brain. So putting this together, this is obviously a surgical emergency needing to be treated and patched up immediately. Otherwise, you'll start to reach kind of larger stroke-like pictures. As I think Dr. Z talked about in her lecture yesterday, really important topic, very important for wards that know how to treat a stroke. So that is everything from me. Happy to take questions. I know there's a lot going on this next couple of weeks. I'll stay after to answer any more questions as well. And if there's no questions, get out there, enjoy the beautiful day before you got to go back into lab.